Hello, welcome you all to my YouTube channel. Today we're going to learn about Myringoplasty, introduction and learning objectives. Definition: Myringoplasty is the surgical repair of the tympanic membrane TM perforation. A type 1 tympanoplasty Wolstein classification means only the TM is repaired, with the acicular chain intact and mobile. Key learning objectives list the common causes and presentations of a TM perforation. Describe the indications and absolute contraindications for myringoplasty. Compare and contrast the underlay and overlay surgical techniques. Identify common graft materials and their ideal use cases. Discuss the factors that influence surgical success and potential complications. Why do perforations happen? Infection: the most common cause of acute perforation is acute otitis media, AOM. Healing: 70 to 80% of acute perforations heal spontaneously within 30 days. Factors hindering healing: tympanosclerosis, malleus injury, ongoing infection, large size. Trauma: direct cotton buds, slaps, foreign objects. Indirect barotrauma: flying, diving, temporal bone fractures. Iatrogenic: most commonly from the extrusion of ventilation tubes, VTs. Key stat: short-term VT risk 2.2%, long-term VT risk 16.6%. Patient presentation: what do they feel? Asymptomatic: small perforations may be found incidentally. Oturhoia: discharge. Mucoid or mucopurulent discharge is a red flag for a TM defect. Mucus glands are in the middle ear, not the EAC. Managed with microsuction topical antibiotics. Ototoxicity alert: aminoglycosides E.G. Gentamicin are ototoxic. Quinolones E.G. Ciprofloxacin are preferred in perforated ears. Hearing loss: conductive. Hearing loss, CHL. Magnitude depends on size and location. Small perforations may have no loss. Large perforations can cause a moderate CHL. Perforations affect low frequencies more than high. 60 dB CHL suggests ossicular chain involvement E.G. Discontinuity. Decision-making: to operate or not. Indications for surgery: recurrent infections, oturhoia, affecting quality of life. Hearing loss deemed significant by the patient. Social reason: to allow swimming without water precaution. Absolute contraindication: cholesteatoma. The disease must be eradicated first. Repairing the TM over a cholesteatoma is a critical error. Relative contraindications weigh risks, benefits. Contralateral dead ear, risk of hearing loss in only hearing ear. Severe Eustachian tube dysfunction, high chance of failure. Uncontrolled comorbidities, diabetes, smoking, malnutrition. The operation, grafts and techniques. Graft materials: temporalis fascia, the gold standard, easy to harvest, abundant, reliable. Tragal cartilage, increasingly popular, more rigid, used for large perforations, epitheliocelmae, for vision surgery and poor Eustachian tube function. Long-term hearing outcomes are equivalent to fascia. Others: perichondrium, fat, paper patch for small dry perforations in clinic. Surgical techniques: underlay technique. Graft placed medial to the TM remnant. Pros: technically easier, faster healing, fewer complications. Access to anterior margin can be difficult. Overlay technique: graft placed lateral to the TM remnant but medial to the annulus. Pros: excellent visualization of anterior annulus. Cons: higher risk of iatrogenic cholesteatoma 4.4%, and anterior blunting. Factors influencing success and complications. Prognostic factors: age. Often wait until 7 years old for eustachian tube maturity. Smoking, a modifiable risk factor part of the Mary score. Contralateral ear. A normal ear suggests good overall ET function. Infection, presence at surgery does not seem to negatively impact success. Adenoidectomy. Evidence shows no benefit to myringoplasty success rates. Mastoidectomy. No evidence supports doing it routinely for uncomplicated perforations. Complications. Reperforation, most common, especially in children. Graft retraction can be mitigated with cartilage. Anterior blunting,